Hello students, am I audible?
Yes, sir.
Yes, sir.
Yes, sir.
Yes, sir.
Yes,
Yes,
sir.
sir.
Yes, sir.
Okay students, so today's topic of this lecture class is nerve conduction study. Uh, this is a practical topic, truly speaking it is a practical topic. But as this is a demonstration topic only and you don't need to perform it. So I thought it to be discussed in place of lecture classes. Okay, so the topic is nerve conduction study, right? So before proceeding to the nerve conduction study, we need to know a little bit on the classification of nerve fibers and a little bit knowledge on neuropathy. So we divide our discussion into our learning objectives of this class, right? Then the aim of this practical, or you can say this class. Then neuropathy basic concept. What is neuropathy and how can we classify neuropathy? Then sensory and motor nerves, sensory and motor nerves for nerve conduction study. So basically in nerve conduction study, we study our sensory and motor nerves, sensory nerves in our upper limbs, like your the radial nerve, the median nerve, your ulnar nerve, and in case of lower limb, the common peroneal nerve, tibial nerve, sural nerve, right? So these are the nerves we commonly use for our study, nerve conduction study. Then we will show you the equipment for nerve conduction study. Again, I'm repeating that it is a demonstration topic and you don't need to perform nerve conduction study in your examination. It is a time taking investigations, and to definitely nerve conduction study is to diagnose a case of neuropathy, right? To diagnose a case of neuropathy. What is neuropathy? So neuro means nerve and pathy means related to some pathology. So that means your nerve, be it a sensory nerve or be it a motor nerve, somehow it is damaged. So maybe there are two types of damage in nerves. One is the damage of the myelin sheath. You know that a nerve looks like, a typical shape of the neuron you have drawn in your 10+2, right? So a typical shape of neuron. So we have a cell body, right? We have a cell body, then we have axons, and over the axons we have the myelin sheaths, right? So we have myelin sheaths. Okay, so either the myelin sheath may be damaged, and we call it, demyelination, right? Demyelination. And once the axon is damaged, we call it axonal neuropathy. Okay, axonal neuropathy. So demyelinating neuropathy or axonal neuropathy. Neuropathy means simply damage to nerve fibers, and this damage might be the demyelination of the nerve fibers, that is damage to myelin sheath. And another part of neuropathy is axonal neuropathy, and very frequently during our investigation, many patients they suffer from both the types, that is both demyelination and axonal damage, right? Okay. So next is the mm, procedure for nerve conduction study. So for our discussion in this class, we will be dealing with median nerve motor nerve conduction study and median nerve sensory nerve conduction study, and finally we will deal with the precautions, right? Okay, so what is the specific learning objective? To learn the skin for stimulation of median nerve at wrist and at the elbow, identify the stimulating, recording, reference and ground electrodes, and identify the region where they are to be placed, and enumerate the conditions where a nerve conduction study and amplitudes are, nerve conduction parameters, that is velocity and amplitude, are altered, right? Okay.
Yes, sir. Now it's
Yes, sir. Now it's visible.
Okay, okay, thank you. So today's discussion we will divide into few groups. So first of all we will discuss the specific learning objective, then aim of the study, then we will discuss neuropathy, what is the basic concept of neuropathy. So neuropathy neuropathy, first you need to identify, you need to know what is neuropathy, right? Okay. Just a minute. So first is, what is neuropathy? So neuropathy is simply defined as damage to a nerve fiber, right? When a nerve fiber is damaged due to injury or due to many toxins or due to maybe some disease process. So there are lots of disease processes that damage our nerves, right? And we call it neuropathy. And mostly what is damaged is your nerve fiber. Okay. So typically you have drawn a neuron, right? So this is simply a neuron you have already drawn in your 10+2. So a nerve fiber, it contains myelination, and within it we have the axons, right? So once the myelin sheath is damaged, we call it demyelination. Okay, we call it demyelination. And when the axon is damaged, it is called axonal neuropathy. So neuropathy is of two types. One is demyelination neuropathy and another is axonal neuropathy, right? So very simple. Neuro means nerve and pathy means due to some disease process it is damaged. So nerve fiber is damaged, it may be demyelination or it may be damage to the axon. So demyelinating neuropathy and axonal neuropathy, these two are the major arms of neuropathy, right? Okay. So to perform this study, it is an investigation. Very commonly, you will see that in case of a diabetic patient, very commonly doctors prescribe nerve conduction study. It is an investigation. So with this nerve conduction study, we can determine whether the patient is suffering from any demyelination disease or axonal disease, and very frequently it may also happen that the patient is suffering from both the varieties, that means mixed neuropathy, that is demyelination and axonal neuropathy, right? Okay. So for nerve conduction study, we choose some sensory nerves in our upper limb and some motor nerves in our upper limb and also in our lower limbs. So in upper limbs, we choose radial nerve, ulnar nerve, then median nerve, right? And in case of lower limb, common peroneal nerve, posterior tibial nerve, sural nerve, these are the nerves very frequently we use for nerve conduction study. Then we will show you the equipment for nerve conduction study. Then we will discuss the procedure of nerve conduction study. You don't need to know all the nerves, but as a representative of all the nerves, as median nerve is the major nerve in your upper extremity or upper limb, and median nerve has got the sensory component and the motor component. So we will be using motor median nerve as a representative to teach you nerve conduction study, right? And finally we'll discuss the precautions. So moving forward, these are the learning objectives and aim.
Sir,
Skipping. Yes, any question?
yes, sir. What is CMAP?
Okay, I'll be coming to it. Action potential, right? Action potential, and CMAP is compound muscle action potential, and SNAP is sensory nerve action potential, right? So basically, in nerve conduction study, we will measure the electrical activity of a muscle in terms of action potential, and we will call it compound muscle action potential, when we will be checking the motor nerve of your upper extremity, say for example median nerve, right? So for example, okay, I'm coming to it. Okay, so right now just remember, CMAP is compound muscle action potential and SNAP is sensory nerve action potential. Okay. The concept of neuropathy is clear to you. Simply consider a neuron, axon, and its myelin sheath. So once myelin sheath is damaged, we call it demyelination. And when axon is damaged, we call it axonal neuropathy. So neuropathy is mainly of two types. And in physiology, we will be looking neuropathy with these two arms. One is demyelination neuropathy and another is axonal neuropathy. But maybe in a clinician or a physician, he is more concerned with different with a different classification of neuropathy. He or she might be calling it, large fiber neuropathy or small fiber neuropathy, maybe sensory neuropathy and motor neuropathy, right? So there are lots of ways we can classify neuropathy, right? So physiologically, or if we focus on the pathology, what is happening or what is the disease process, the best classification is always axonal neuropathy and demyelinating neuropathy. And nerve conduction study is the way you can differentiate between these two different disease process, whether the patient is suffering from axonal neuropathy or demyelinating neuropathy, right? Okay. So first, what you need to know, which is the basic understanding, basic prerequisite to understand nerve conduction study, is the classification of nerve fibers. How do we classify nerve fibers? So according to Erlanger and Grasser, they have classified nerves into different categories. So first is A fiber, right? Then B, and finally C. So these three are the major classification of nerve fibers. Under A, we have A alpha. First question is, have you read this classification? Have you studied this classification?
No, sir, no.
Okay. Okay. So there are different nerves in human body, but all those nerves are not myelinated, right? So all those nerves are not myelinated. Some of the nerves are myelinated and some are not, right? So in this classification, Erlanger and Grasser, the name of the scientist or physiologist, so they have classified nerve fibers according to their diameter, right? And I guess all of you know that once a nerve fiber is having myelin sheath, it has got high velocity, right? So myelin sheath, the more is the
Yes, sir.
myelin sheath, the more is the velocity in a nerve fiber. So in this classification, A under A, we have A alpha, A beta, A gamma, and A delta, right? So from top to bottom, diameter is decreasing. Okay. From top to bottom, diameter of the nerve fiber is decreasing and velocity is also decreasing. So you see here velocity. So velocity for, say for example, 1 alpha, it is having velocity of 120 to 70 meter per second, then 70 to 30 meter per second. So you can see the gradually velocity is decreasing. All of you are requested to mute yourself until and unless you need to talk. Okay. So from top to bottom, A alpha to C, you can see velocity is gradually decreasing, and also you can see that diameter is also decreasing, right? So you can say the more is the diameter, the more is the velocity, right? So in a nerve fiber, the speed of action potential, increases when the nerve fiber is myelinated. And as myelination decreases, velocity also decreases, right? The more is the myelin sheath, the more will be the velocity, right? So in this classification, you can see that A alpha fiber is having the highest myelination, highest degree of myelination, and as a result, it has got the highest velocity. So A alpha fiber, it has got the largest diameter due to increased myelination and also increased velocity, right? Now, if someone asks you, uh, name a nerve fiber which is unmyelinated. Okay, name a nerve fiber which is unmyelinated. Answer is C. C fiber is C. Yes, C. The last one. So C is unmyelinated. A alpha is having the highest degree of myelination. Then myelination gradually decreases from A alpha to A beta to A gamma. A delta is also having least myelination. B is also having slight myelination, but C is unmyelinated or non-myelinated, right? Okay. Now A alpha fiber, A beta fiber, These are large diameter fibers. A alpha and A beta, these are large diameter fibers. I guess you know A delta fiber, A delta and A gamma fiber. A gamma fiber is the gamma motor neuron, what you have studied in stretch reflex, right? In stretch reflex, the gamma motor neuron, which supplies the muscle. So gamma motor neuron, it is purely motor, right? Now you need to know the nature of all these nerves. A alpha fibers. A alpha fibers, it can be alpha motor neuron in stretch reflex. You know, in stretch reflex, there is alpha motor neuron, and alpha neuron may also be proprioceptive neuron. So this A alpha is a mixed neuron, right? A alpha is a mixed neuron. It can be sensory or it can be motor. When it is sensory, it carries proprioception. Proprioception means joint position sense, right? Proprioception means joint position sense. Okay, then A beta. A beta is purely sensory and it carries touch sensation, touch and also pressure sensation, afferent for touch and pressure, right? Okay, then A gamma, gamma is gamma motor neuron, what you have studied in stretch reflex. A delta is the pain carrying fiber, pain and temperature, okay, thermal senses and pain, correct. A delta is for pain, B is preganglionic fiber for autonomic system, and C is postganglionic sympathetic. Okay, C also carries pain. Okay, so what are the fibers that carry pain?
The C fibers.
A delta and C. Okay, A delta and C. These two fibers are responsible for pain and temperature, right? A beta. A beta is touch and pressure, right? A beta is touch and pressure. A beta is touch and pressure. A alpha is proprioception. Okay. Do you know what is proprioception? Anyone? What is proprioception?
No, sir. We don't know. Please elaborate.
Okay. So proprioception means if I ask you to stand and close your eyes, okay. If I ask you to stand and close your eyes, you still know that you are standing, right? So this is
Yes, sir.
because and you know your eyes are closed, and if I raise your right arm and keep it as such, right, and I told and I advise you or I direct you to keep it as such, right arm, you know that your right arm is elevated, right? And also if I make you sit with your eyes closed, you still know that you are sitting even if your eyes are closed. This is because some senses are coming to your cerebral cortex from your joints. You know how your knee joint is, right? Whether it is flexed or whether it is extended, whether your hip joint is flexed or extended. So from all the joints, you have some sensation. That sensation is being carried to your cerebral cortex and you know your position. So this is a specific sensation which is called proprioception. Proprioception, another name is joint position sense, right? So you know how your knee joint is, whether it is flexed or extended, how your elbow joint is, how your wrist joint is. From all the joints, you have a sensation that is being carried to your cerebral cortex and you know your position. Okay, your eyes are closed and you are lying. You still know that you are lying. Okay, you don't need to see yourself to come to the conclusion that you are lying or you are sitting, right? So even if your eyes are closed, you know that you are in a specific position, and that is called proprioception. It is a sense or it is a sensation that is coming from your joint and taken to cerebral cortex. Just like pain sensation, touch sensation, pressure sensation, these are lots of sensory modalities we have. So similarly, proprioception is a sense, and that sense is carried by specific sensory neurons that are A alpha fibers, right? A beta fibers are touch and pressure. A delta fibers are pain sensation, pain or temperature sensing fibers. A gamma are the gamma motor neuron. So this is purely motor. A gamma is purely motor. In case of stress reflex, you have studied that there is an afferent fiber, then efferent fiber, and also the gamma motor neuron which supplies the intrafusal fibers, right? So A gamma is purely motor. Then B and C. B and C are mostly autonomic fibers, but C has also got another component of sensory fibers, that is pain sensing fibers. Okay. So this is classification A, B, and C, and under A, another 4 classification: A alpha, A beta, A gamma, and A delta. And from top to bottom, from A alpha to C, diameter decreases and velocity also decreases, because A alpha is most myelinated and C is completely unmyelinated, right? So you need to remember this classification. A alpha and A beta altogether, A alpha and A beta altogether, they are called A alpha and A beta together called large fiber. Correct. A alpha and A beta are called large fiber, and A gamma is purely motor, and we don't test it. And A delta and C, these two, A delta and C, these two are called your small fiber. What is happening? So A alpha and A beta are large fiber, A delta and C are small fiber. So everyone clear with this classification, so that we can proceed to next.
Yes, sir.
Yes,
Yes,
sir.
sir.
Yes,
Yes, sir. Yes, sir.
Yes,
Yes,
sir.
sir.
Yes, sir.
Okay, this classification is given in all your books, whatever book you are studying, Devashish Pramanik or Ganong, Gaiton, everywhere this classification will be given. Okay. Now, large fiber neuropathy or small fiber neuropathy, right? So before moving here, large fiber neuropathy and small fiber neuropathy, you want to understand right now. So let me show you this. So neuropathy, right? So this is your spinal cord, right? This is your spinal cord, and inside we have the gray matter, and outside we have white matter, right? And at the ventral part or anterior part, we have the ventral root, and this is the posterior part or dorsal root, right? The arrangement is that the sensory nerve, it enters. So this is sensory nerve, right? This one is sensory nerve. So in this spinal cord, one law is there. That law is called Bell-Magendie's law. Bell-Magendie's law. And according to this Bell-Magendie's law, in this spinal cord, dorsal root is sensory and ventral root is motor, right? Dorsal root is sensory and ventral root is motor. So I guess you have studied knee jerk in your 10+2. So when we strike over the patellar tendon, right? When we strike over the infrapatellar tendon, so quadriceps muscle is stretched, right? And this stretch sensation is carried through the dorsal ramus, right? In this way, through this dorsal ramus, stretch sensation goes into the spinal cord, right? Goes into the spinal cord, and it synapses with a motor neuron, right? It synapses with a motor neuron, and this motor neuron exits through the ventral root, right? So in the spinal cord, dorsal root is sensory and ventral root is motor. Through dorsal root, your sensory nerve enters into the spinal cord, and through ventral root, your motor fiber exits from the spinal cord, right? And as a result, you see the jerk, right? In case of knee jerk, and the root value is L234, right? Lumbar 2, 3, and 4. This is the root value of knee jerk. So this is just an example. So what to memorize from this area is in the spinal cord, dorsal root is sensory, through which the sensory nerve enters into the spinal cord, and ventral root is motor, and from the ventral root your motor nerve emerges. Now this sensory nerve has got cell body in the DRG. DRG is dorsal root ganglion. Okay, this is dorsal root ganglion. So the cell body of sensory nerve is located in the dorsal root ganglion. It is basically this sensory nerve is basically a bipolar neuron. Correct. Okay. Now you see this picture. So as a whole, this is the spinal cord. You can see the gray matter and white matter, and you see the sensory nerve or afferent, which is green in color over here, and you see this sensory nerve is. Let me. Okay. So this is the ganglion or dorsal root ganglion, right? Ganglion is nothing but the cell body of this neuron, right? So this sensory nerve has got two poles, okay, two axons. So this is the direction of sensation, which is moving into the spinal cord through the dorsal root. This is dorsal, and this is ventral root, right? Okay. Now, injury can be anywhere in case of spinal nerve. Injury can be here at the root. We call it radiculopathy, right? Or the nerve root is damaged. Okay. So either dorsal root or ventral root can be damaged. We call it radiculopathy. That means it is not neuropathy, it is radiculopathy, right? That means nerve root is damaged. Now, once the nerve root emerges from the spinal cord as a spinal nerve, so when the damage is at the periphery, we call it neuropathy, right? So when the damage may also be at the ganglion, and we call it ganglionopathy. So there are lots of areas where a nerve can be damaged. So simply you consider a stretch reflex. So if this is stretch reflex, say this is quadriceps tendon, right? So this is quadriceps tendon. So you stretch it with a hammer, right? You stretch it or strike it with a hammer, and you will see the muscle contraction, right? So this, it makes a complete circle. The afferent nerve, the integration center here, and the efferent nerve, right? Afferent nerve here is green in color, and the efferent nerve or the motor nerve is red in color, right? Okay. Now, if the damage is at the level of spinal cord, we call it myelopathy. If the damage is here at the root, we call it radiculopathy. If the damage is at the level of ganglion, we call it ganglionopathy. And if the sensory and motor nerve is damaged here at the periphery, we call it neuropathy, or simply peripheral neuropathy. Basically, we call it peripheral neuropathy. And remember, with the nerve conduction study, what is the practical topic today? With nerve conduction study, we detect any damage in the peripheral nerve. That means we detect the peripheral neuropathy, right? Okay. So there are lots of
হলে কি বললেন?
হ্যাঁ
স্পাইনাল কর্ডে হলে কি বললেন?
myelopathy
স্পাইনাল কর্ডে?
myelopathy
না না না, স্পাইনাল কর্ডে হলে ওটা মাইলোপ্যাথি।
হ্যাঁ।
আচ্ছা।
Where the damage is at the level of muscle, we call it myopathy. Okay. When is damage is at the level of spinal cord, it is myelopathy. When the nerve root is damaged, the dorsal horn, the dorsal root or the ventral root is damaged, we call it radiculopathy. And when the peripheral nerve is damaged, we call it peripheral neuropathy. And nerve conduction study, that is today's practical topic. Nerve conduction study is an investigation or is a test to detect any peripheral neuropathy. Clear?
Yes, sir.
Okay. Okay. Again, I'm coming back to this classification because there is a purpose. So you see A alpha and A beta, right? So these two fibers are mostly myelinated, right? These two fibers are mostly myelinated, and the maximum damage to A alpha and A beta fibers will be due to demyelination. And when these nerve fibers will be damaged, so what will happen? So the function of A alpha is proprioception, right? You see, the function of A alpha is proprioception, and it can also act as a motor nerve, right? So when A alpha will be damaged, so depending on whether this A alpha is motor nerve or proprioceptive nerve, the manifestations in the patients can vary, right? So if A alpha is a motor nerve, what will happen? There will be paralysis, right? Or weakness of this muscle. And when A alpha is proprioceptive nerve, so you know that proprioception is a sensation that comes from your joint, and you know the joint position senses. You know the joint position even when your eyes are closed, right? So this is proprioception. So when A alpha is damaged, your proprioception will be lost. Clear? Your proprioception will be lost, and if if you close your eyes, and you will not be able to know your position. Correct? And we test it by a very simple test called Romberg test. Okay, we call it Romberg test, ROMBERG, Romberg test. With this Romberg test, simply you ask the patient to stand and ask the patient to close his eyes, and you see for the presence of any swaying movement sidewise of the patient. So if the patient sways and about to fall, then Romberg test is positive, and we call it sensory ataxia, right? We call it sensory ataxia. Sensory ataxia. Correct? So similarly, A beta fiber is for
Sorry,
touch.
ataxia মানে আরেকবার বলবেন?
So the thing is, the classification of nerve fibers, A alpha, beta, A gamma, A delta, all these are arranged according to their myelination, right? Myelination is highest in A alpha, right? Myelination is highest in A alpha, and A alpha is responsible for, motor and proprioception, right? So when your A alpha is motor and it is damaged, that means there will be weakness, there will be paralysis of that muscle, right? And when A alpha is proprioception or proprioceptive nerve fiber, that means proprioception will be lost, right? The patient's proprioception will be lost, and patient doesn't know his or her joint position, right? Like for example, I am sitting right now on a chair, and I'm taking your online class, and I know I am sitting. Even if I close my eyes, I know that I am sitting, right? So this is proprioception, and this proprioception is carried by A alpha fibers. But when your A alpha fibers are damaged, right, you don't know your position. Correct? So frequently what happens, we test it with the typical test called Romberg test. So if you ask the patient to stand, right? If you ask the patient to stand and hands or arms stretched on both the sides, and you ask the patient to close his or her eyes, and you check for any swaying movement of the patient, whether the patient is swaying and whether the patient is about to fall, right? So if this is happening, the patient is swaying sidewise or about to fall, right? So this is called definitely for doing this test, you need to safeguard the patient so that the patient the patient does not sustain any injury after falling. You should prevent that, right? So once the patient is swaying and about to fall, we call it Romberg test positive, right? Romberg test positive. That means there is presence of sensory ataxia. Okay. Okay. So similarly, A beta fibers, you see A beta fibers, it is for touch sensation and pressure sensation, right? A beta fiber, it is for touch sensation and pressure sensation. So when A beta fibers will be damaged, patient's touch sensation, pressure sensation will be gone, right? So once you touch the patient cannot identify that something is touching my skin, right? Okay. So A alpha neuropathy or A beta neuropathy, these two are large fiber neuropathy, right? Large fiber neuropathy. Why large fiber? Because these fibers are thick enough. These fibers are myelinated, right? And very typically, these neuropathies are demyelinating neuropathy due to damage to myelin sheath, right? Okay. Now A delta and C, these fibers are small fiber neuropathy, and A delta fiber, both A delta and C, they are pain sensation fibers, pain and thermal sensation. Actually, these two sensory modality, pain and temperature, are equivalent, right? High degree of temperature is equivalent to pain, and A delta and C fibers are for pain sensation, right? Okay, now we will see what will be the differences in patients with large fiber neuropathy and small fiber neuropathy. So large fiber neuropathy means A alpha and A beta will be damaged, and small fiber neuropathy means A delta and C fibers will be damaged, right? A alpha and A beta, large fiber neuropathy, A delta and C, small fiber neuropathy. A delta is having minimum myelination and C is having no myelination. Clear?
Yes, sir.
Yes, sir.
Now
Yes,
we are
sir.
coming to large fiber neuropathy and small fiber neuropathy. So small fiber neuropathy, large fiber neuropathy is A alpha and A beta, right? These are large fiber neuropathy, and small fiber neuropathy is A delta, which is having least myelination, and C. Okay,
Sir?
so first C,
Sir.
yes,
Sir, A delta is mixed type of nerve. A delta
A delta is sensory nerve. A delta is not mixed.
and C.
C is autonomic. You see, C is autonomic, and C is also used for pain sensation, right?
Okay. Hmm.
Mixed is A alpha. Sometimes it is motor fiber, and sometimes it is proprioception or sensory fibers, right?
Sir, A gamma.
A gamma is purely motor. A gamma is purely motor, right?
Purely motor,
So
huh?
C A gamma is motor nerve to intrafusal fibers.
And A beta is purely sensory.
A beta is purely sensory for touch and pressure.
A
Okay.
alpha.
A alpha is
Mixed,
both sensory and motor.
Mixed.
A alpha is mixed, both sensory and motor. Which specific sensation A alpha carries? Proprioception. Which specific sensation A beta carries? Touch and pressure. Which specific sensation A delta carries? Pain and temperature. Which
And C
specific
also.
sensation C carries? Pain.
Okay.
Correct? Clear? Okay.
Yes, sir.
And out of this classification, motor is only A alpha and A gamma. A gamma is purely motor, and A alpha sometimes motor, sometimes sensory.
Sometimes sensory.
Okay, clear. Now moving on to the difference between large fiber neuropathy and small fiber neuropathy. So large fiber neuropathy means A alpha and beta, right? So large fiber neuropathy may be axonal, may be demyelinating because it is having myelination, right? So this A alpha and A beta, so it has got axon and it has got myelin sheath as well. Correct? But A delta and C, it has got least myelination or no myelination, only the naked axon, right? Clear? Only axon, and it has got myelin sheath and axon, right? So A alpha and A beta might be damaged due to demyelination or due to axon damage, correct? But small fiber neuropathy, it is only axon, right? Only axon. So neuropathy will be only axonal damage. Clear? And large fiber neuropathy, it may be axonal neuropathy or it might be demyelinating neuropathy. Whether this part is clear to you or not.
Yes, sir. Yes.
Okay.
Yes, sir.
Okay, now you see that A alpha and A beta, they don't have any autonomic component, right? So in this classification, you see A alpha and A beta, they don't have any autonomic component. So A alpha and A beta, they are never autonomic fibers, at least. Okay, they might be sensory, they might be motor, but they are never autonomic. But A delta and C, you see, C fibers can be autonomic, right? C fibers can be autonomic because C fibers you see postganglionic sympathetic other than pain sensation, right? Okay, so no autonomic involvement in case of large fiber neuropathy, and autonomic involvement will be there in small fiber neuropathy. Sensory ataxia Rombach test positive, it will be here in large fiber neuropathy, and no sensory ataxia in small fiber neuropathy. Motor involvement will be here in large fiber neuropathy because once alpha is damaged, and alpha is motor, there will be motor involvement. And there is minimum motor involvement or almost no motor involvement in A delta and C. Because A delta and C, they do not have any motor component, right? When A alpha fiber is damaged, patient will be having cotton wool sensation, numbness, মানে কি ভারী ভারী লাগছে, হাত পা ভারী ভারী লাগছে, ঠিক আছে? So numbness, cotton wool sensation, these are features of large fiber neuropathy. And small fiber neuropathy, the patient will be complaining of shooting pain and burning pain, right? Deep tendon reflex, just for example knee jerk, it will be lost in case of large fiber neuropathy, and deep tendon reflex will be preserved in case of small fiber neuropathy. Large fiber neuropathy, it is proximal to distal, that means your proximal muscles will be paralyzed first, right? But not paralyzed, proximal features will be proximally if it is demyelinating or axonal, as because you know that motor involvement is here, so might be paralysis here, proximal to distal, right? And this is proximal to distal. And small fiber neuropathy, it is distal to proximal, and it is usually sensory in gloves and stocking pattern. Okay, in gloves and stocking pattern. So if you wear gloves and you know stockings or socks, right? So very typically it is gloves and the sensation, this typical sensation, shooting pain, burning pain, all these
স্যার
will be
ডিপিআরটা কি?
deep tendon reflex. For example, knee jerk, biceps jerk, triceps jerk, right? These are deep tendon reflex. হ্যাঁ, তোদের রিফ্লেক্স পড়া হয়নি?
হ্যাঁ হ্যাঁ হ্যাঁ
রিফ্লেক্স পড়া হয়েছিল তো?
Sir, what's ataxia?
হোয়াট ইজ অ্যাটাক্সিয়া? এতক্ষণ ধরে তো সেটা বোঝালাম, অ্যাটাক্সিয়া কি। ওকে,
রিক্যাপ করে দিন না স্যার একটা ছোট করে।
Ataxia means just loss of balance, right? Loss of balance. You know, your balance is controlled by many parts in your body. So one is vestibular system, which is located in your inner ear, right? Vestibular system, it also causes your balance. Your cerebellum is responsible for your balance. And another system that is located, that is required for your balance, is the alpha neuron, A alpha neuron, which carries proprioception from your joints to your cerebral cortex. Okay, ataxia means loss of balance, disbalance. Okay, and when it is an ataxia may be cerebellar ataxia due to problem in the cerebellum, or ataxia may be due to problem of vestibular nerve, right? We call it vestibular ataxia. And ataxia also might be due to sensory disturbances or sensory nerve damage. Which sensory nerve damage? A alpha, right? When A alpha is damaged, the patient might be having balance problem, because it is not coming from your joints to your cerebral cortex, right? So these are the features of A alpha, A beta fiber, that is large fiber neuropathy, A delta and C fiber, that is small fiber neuropathy. I guess you are not understanding because I am not giving you any example of a disease. Okay, so for example, the most common disease which I can give you example of is say for example diabetes, right? So diabetes is a disease, you know, when a patient suffers from diabetes for a long time, you know, 5 to 10 years of uncontrolled diabetes, the patient will be having neuropathy because nerves will be damaged due to hyperglycemia, high blood sugar. It causes neuronal damage, and initially at the start, to start with this neuropathy, three complications of diabetes, neuropathy, your nerve is damaged; retinopathy, your retina is damaged; and also nephropathy, your kidney is damaged. So we are concerned with the neuropathy. So a long-standing diabetic patient with neuropathy, right? So what kind of neuropathy in diabetes is? It is, to start with, it is axonal neuropathy. So initially axons are damaged, right? Initially axons are damaged, or axonal neuropathy, and it is small fiber neuropathy to start with, right? So a long-standing diabetic patient will be complaining of shooting pain, okay, shooting pain, burning pain, okay, shooting pain and burning pain, but there will not be any paralysis. That means deep tendon reflex will be preserved, right? Deep tendon reflex will be preserved. And how this shooting pain, burning pain is characterized? It is gloves and stocking pattern, right? Gloves and stocking pattern माने in your hand, हाथ में आप जहाँ पर gloves पहनते हो, तो वो एरिया यहाँ पर होगा, और जहां पर आप सॉक्स पहनते हो इस एरिया पे होगा ग्लव्स एंड स्टॉकिंग पैटर्न। इन दिस एरिया में आपको शूटिंग पेन, बर्निंग पेन या फिर इलेक्ट्रिक शॉक लाइक पेन, ये सब सेंसेशन आएगा। ठीक है, clear? So small fiber neuropathy example is diabetes mellitus. Okay, at the beginning, remember at the beginning, diabetes is not always small fiber neuropathy. In late diabetes, it also involves the large fiber and proximal neuropathy as well, right? So initially in diabetes mellitus, there will be small fiber neuropathy. That means A delta and C fibers will be damaged. And A delta and C fibers, they are carrying pain sensation, right? So the patient, once this A delta and C fibers are damaged, the patients will be having abnormal pain sensation, shooting pain, burning pain, right? Without any stimulus, the
pain
patient
থাকার
will be
কথা
having
আছে?
such kind of pains. Yes,
Sir, there should be no pain because the fibers are damaged.
that is complete damage, dear. Okay, when the fibers are completely cut off, then only sensation will be completely lost, right? So during the period of damage, the patient will be having shooting pain, burning pain, right? All abnormal pain sensations will be there in case of small fiber neuropathy. But remember, deep tendon reflex will be preserved in case of small fiber neuropathy, because in case of deep tendon reflex, A delta and C fibers are not required, right? The alpha motor neuron, which is required for deep tendon reflex, is here in large fiber, right? So deep tendon reflex, or for example knee jerk, this might be lost in case of large fiber neuropathy, correct? Large fiber neuropathy is characterized by sensory ataxia, Rombach test positive, because patient will not be having proprioception or joint position sense, which is carrying your joint position sense from all the joints to your cerebral cortex, right? So these are the differences between large fiber neuropathy and small fiber neuropathy. Okay, now let us come to few examples of large fiber neuropathy and small fiber neuropathy. You see, under small fiber neuropathy, I have first written DM, or diabetes mellitus, right? So all the diseases you don't know, just you can remember one or two. So small fiber neuropathy, don't forget diabetes mellitus, and large fiber neuropathy, don't forget vitamin B12 deficiency and Guillain-Barré syndrome, right? So these two or three I want you to remember: HIV drugs, uremia, leprosy, right? So these are important causes of small fiber neuropathy, right? And also remember, diabetes mellitus, late diabetes mellitus is also a cause of large fiber neuropathy. Late diabetes mellitus is also a cause of large fiber neuropathy. So diabetes mellitus, to start with, it is a small fiber neuropathy where A delta and C fibers are damaged, and large fiber neuropathy gradually are involved, that is A alpha and A beta, correct? So whether autonomic involvement will be there in diabetes or not, autonomic involvement means what are autonomic functions? Urination, defecation, these are all autonomic functions, sweating. So these are all autonomic function, right? Controlled by the sympathetic and parasympathetic system. So your bladder control, that means urine control, bowel control, okay, So these are all autonomic functions. So whether autonomic functions will be preserved in diabetes or autonomic function will be gone in diabetes.
Sir, it will be preserved.
Why? A delta and C fibers are affected.
Sir, it will be gone.
Sir, because it is responsible for the autonomic response, A delta and C. In
A
early,
delta is not autonomic. Again, come to the classification. You see that C fibers, C fibers, C fibers, last
C,
C fibers. It is preganglionic sympathetic, right? So C fiber once gone, there will be sympathetic disturbances, right? But A alpha, A beta, you see in case of large fiber, there are no actions, no autonomic actions, only motor and sensory, right? Okay, so in case of diabetes mellitus, initially it is a small fiber neuropathy and autonomic involvement will be there. Okay, so patient might be complaining of urination problem, defecation problem, like that. Okay, so don't remember all the diseases you have not studied, and I don't want you to remember all the diseases, but just for example, for small fiber neuropathy, diabetes mellitus, you remember, and if possible remember two more like leprosy, HIV drugs, and under large fiber neuropathy, B12 deficiency and Guillain-Barré syndrome, right? So for B12 deficiency, B12 is what?
What is that GBS, sir?
GBS is a paralytic disorder. Full form is Guillain-Barré syndrome. Okay, it is a paralytic disorder, most commonly a sequelae of viral infection. There are also few cases of Guillain-Barré syndrome after COVID infection during the first wave of COVID. Okay, right now it's not happening. Okay, so B12 deficiency, Guillain-Barré syndrome, these are causes of large fiber neuropathy. That means your A alpha fiber, A beta fibers will be damaged, right? Okay, so large fiber neuropathy, small fiber neuropathy. Okay, so this one I have already told. What are the nerves that we used in nerve conduction study? In the upper limb, your median nerve, radial nerve, ulnar nerve. In the lower limb, sciatic nerve, femoral nerve, tibial nerve, common peroneal nerve, sural nerve, right? And sometimes doctors also advise specific, if someone is having any tingling sensation or numbness or electric pain sensation, shooting pain sensation in the upper limb, doctor might prescribe specific nerve conduction studies. Say for example, doctor has advised of right median nerve. Okay, so we can prescribe NCS as a whole. So once NCS or nerve conduction study is prescribed as a whole, we need to perform in the upper limb, median nerve, radial nerve, ulnar nerve, and also in lower limb, sciatic nerve, femoral nerve, tibial nerve, common peroneal, and sural nerve, right? And very often, doctors also prescribe specific nerve conduction study. Say, for example, nerve conduction study of the medial nerve. Okay, and in this class, we will be discussing only the nerve conduction study of the median nerve. Okay, so what equipments are required? So remember, with nerve conduction study, we just differentiate between axonal and what?
Demyelinated, sir.
Demyelinating neuropathy. Axonal and demyelinating neuropathy. Right. So the purpose of performing nerve conduction study is to differentiate between axonal and demyelinating neuropathy. And you already know that axonal neuropathy is usually small fiber, not always, usually small fiber, and demyelinating neuropathy is usually large fiber. Right. Demyelinating, that means माइलिनेशन होगा तभी ना डिस्ट्रॉय होगा माइलिनेशन, ठीक है? So माइलिनेशन किस में होता है? लार्ज फाइबर्स में होता है, right? So demyelinating neuropathy is usually large fiber neuropathy, but large fiber neuropathy might be axonal or demyelinating, right? So axonal neuropathy is usually small fiber neuropathy. Oh God, what is happening? Okay, so axonal neuropathy is usually small fiber neuropathy. Axonal neuropathy is usually small fiber neuropathy. That means A delta C, and demyelinating neuropathy is usually large fiber neuropathy, right? A alpha and A beta damage. Clear? Okay. Now nerve conduction study का जो equipment है, just look. This is the equipment. Okay. There are lots of manufacturers that produce this machine. This is a nerve conduction study equipment. Currently, we do not have nerve conduction study equipment in our physiology department at Santiniketan Medical College, because it is a postgraduate topic, but MD topic. But for MBBS, you need to know the principle of nerve conduction study, but you don't need to perform nerve conduction study. In MD, you need to perform nerve conduction study. Okay, so this is the machine of nerve conduction study or NCS equipment. So we need nerve conduction recording device, the surface electrode, the electrode paste, the micropore tape, and spirit cotton, right? So these are the requirement to perform nerve conduction study. This is the equipment. Now see the electrode. Just remember, not like ECG, we have some different electrodes over here, right? So this is called the cup electrode. Okay, this is called the cup electrode. Someone has unmuted yourself, please mute. Okay, so this is cup electrode, and this one is the stimulating electrode, right? Stimulating electrode. Stimulating electrode, right? And this one is ring electrode. Ring electrode for sensory NCS, for sensory nerve conduction study, correct? Okay, now how to perform this nerve conduction study? So median motor nerve, do you have supex in anatomy? Superior
No, sir.
extremity in anatomy?
No.
No.
No, sir.
No, sir. No, sir.
Okay, so here is median nerve, right? Median nerve is a nerve that comes from your brachial plexus. Median nerves, it comes like this, right? So this is the course of median nerve, and it supplies, this muscle. This muscle. What is this muscle? Chyon.
স্যার ওটা তো মানে তারা গুগল করে দেখতে হবে সেটা।
Baba. Okay. So this muscle is abductor pollicis, right? Abductor
pollicis
pollicis.
longus.
No, brevis.
Brevis, okay.
So abductor pollicis brevis. Abductor pollicis brevis, right? So this muscle, the thenar eminence, this eminence is called thenar eminence, and this eminence is called hypothenar eminence, correct? And this muscle on the thenar eminence, abductor pollicis brevis, it is supplied by median nerve, correct? This muscle is supplied by median nerve. Okay, so I will be placing the recording electrode. Recording electrode is the cup electrode, this cup electrode. Okay, so this cup electrode I will be placing here. Okay, cup electrode I will be placing here. So this is the recording electrode R. Okay, this is the recording electrode, and I will apply the stimulating electrode over here at the wrist. Okay, S is the stimulating electrode, correct? So I'll be stimulating over here at the wrist, and I will record the action potential. It is called compound muscle action potential. At the first slide, someone was asking what is CMAP. CMAP is compound muscle action potential. So I'll be stimulating the median nerve over here at the wrist, the stimulating electrode, and I will record the electrical response here at the belly of abductor pollicis brevis, right? Clear? And
Yes,
an
sir.
action potential and an action potential like curve will be generated. And this is called compound muscle. This is not actually action potential. This is called compound muscle action potential, because lots of muscle fibers all together are generating this response. So this is called compound muscle action potential. So see the procedure over here. So this is the stimulating electrode, correct? This is the stimulating electrode, correct? This is the stimulating electrode and this is the recording electrode. Correct. Just a minute. So stimulating electrode and recording electrode, right? This one is the ground electrode. So I'll be stimulating over here with electric current. Okay, very small amount of electric current in millivolt, and I will record here. Okay, and recording I will see on the computer screen, right? Okay, so once I am recording here at the median nerve, we can record, we can give the stimulus to the median nerve, because median nerve is coming in this course, right? This is the course of the median nerve at the front of your forearm, right? So we can stimulate median nerve at point S1 and at point S2, right? And I will be recording here at the thinner eminence R, correct? So while I am stimulating here at the wrist and recording the response, it looks like this, right? And once I am recording at the, once I am stimulating at the elbow, the recording will be like this. So this is the point of stimulus. This is the point of stimulus in case of stimulation at wrist. The latent period is A. So this much is the latent period. After that, we are getting the voltage change, right? And here the latent period is these. Okay. Recording point is at the top of muscle, right? Recording point is at the top of muscle, abductor pollicis brevis. Abductor pollicis brevis के ऊपर हम लोग electrode place कर रहे हैं, and that electrode is called your recording electrode, correct?
Yes, sir.
Recording electrode is R. We are denoting it over here with the letter R. R is the recording electrode, right? S is the stimulating electrode by which you are applying the electric current. Okay, very small amount of electrode current, patient feels a little bit of shock, right? So initially I am applying electrical current at S1, right? And on the computer screen, this one is recorded. Clear?
Yes, sir.
So the latent period is A. Latent period is the time period after which you get the spike, right? This is the point of stimulus and you are getting the spike here, starting from here, just like PR interval in ECG. The latent period after which you get the spike. Okay, I am showing you on the computer screen how it looks like. See, on the computer screen, this is the curve we get, the compound muscle action potential, right? বুঝতে পারছিস না
হ্যাঁ স্যার চলছে
পেরেছিস এবার?
हाँ सर
স্যার বলছি
অল্প
হ্যাঁ স্যার
S1 আর S2 যখন কন্ডাকশনটা করাচ্ছি আমি, তখন A আর B যে লেটেন্ট পিরিয়ডের ডিফারেন্সটা আসছে কেন? মানে রিস্টে
Latent
একবার
period
রেকর্ড
difference
করছি
আসবে
তখন
because when you are stimulating at elbow, that electric current must travel this distance to stimulate abductor pollicis, and once you are stimulating at point S1, it has to travel a little bit to stimulate abductor pollicis brevis, adductor pollicis
সিমুলাসের
brevis.
পয়েন্টসটা আসলে ডিফারেন্সটা আলাদা আছে, ডিসটেন্সটা।
ডিসটেন্স ইজ ডিফারেন্ট। মিডিয়ান নার্ভের লেন্থটা দেখো, মিডিয়ান নার্ভ তো পুরো আর্ম থেকে শুরু
হ্যাঁ,
হয়েছে,
হ্যাঁ।
আর্ম থেকে শুরু হয়ে
ওই জন্যই
রিস্টে
লেটেন্ট
এসে
পিরিয়ডটা
হাতে
আলাদা
আসছে,
আসছে।
ঠিক আছে? সেই জন্য লেটেন্ট পিরিয়ডটা আলাদা আসছে, বুঝতে পারছো কি?
হ্যাঁ স্যার
হ্যাঁ স্যার, হ্যাঁ।
Okay, now latent period is the period after which you are getting the spike. This one is the spike, this is the spike, this is the spike. One positive spike will be there and one negative spike will be there, right? So this is the spike. So latent period difference is B minus A, correct?
Yes, sir.
Yes, sir.
Latent period difference is B minus A. All of you agree?
Yes, sir.
Latent
Yes,
period
sir.
difference is B
Yes, sir.
minus
Yes,
A.
sir.
And this B
Yes,
minus
sir, yes,
A, B minus A, it is measured in millisecond. Okay. So B minus A millisecond is the time period which is required for the nerve impulse to travel from S2 to S1.
Yes, sir.
Okay. Now say for example, the distance between S1 and S2 is C. So you divide B by A by C, it is your nerve conduction velocity.
Yes, sir.
Yes, sir.
Clear?
Yes, sir.
Yes, sir. Yes, sir.
Okay. Okay, so this is how we can calculate the nerve
C by
conduction
B
velocity.
minus হবে তো
সেটা
Yes.
উল্টো হলো তো।
উল্টো উল্টো
হ্যাঁ স্যার
এটা
ভেলোসিটি বাই টাইম হবে
ডিস্টেন্স বাই টাইম
Distance
হবে
by
তো।
time.
ডিস্টেন্স বাই টাইম হবে
Oh, আচ্ছা, sorry,
সি বাই বি বাই এ
হ্যাঁ,
মাইনাস
sorry. C by B minus A. Correct? C by B
হ্যাঁ, স্যার,
minus
ঠিক
A.
আছে।
ইয়েস স্যার।
Clear? C by B minus A is your nerve conduction velocity. Clear everyone? In the unit of क्या होगा यहाँ पर जो भी आप मेजर करोगे, अगर सेंटीमीटर में मेजर करोगे तो सेंटीमीटर पर मिली सेकेंड, तो एनीवे इसको कन्वर्ट करना पड़ेगा इनटू द यूनिट ऑफ मीटर पर सेकेंड. करेक्ट? ओके. So proximal latency minus distal latency. Distance divided by proximal latency minus distal latency. So here in case of proximal latency is B and distal latency is A. Clear? S1 is the distal point, S2 is the proximal point.
ইয়েস স্যার।
Clear?
ইয়েস স্যার।
Yes, sir.
Proximal distal, I guess you know from your anatomy knowledge. Okay. So again, see, this is the latent period or latency. This is the latency L, and A here is base to peak amplitude. A is called base to peak amplitude. Okay, and B is called peak to peak amplitude. Correct? So these are the parameters which we measure in nerve conduction study. You don't need to calculate. Everything is given by the machine. Okay, everything is software generated. How much is the proximal latency? How much is the distal latency? How much is the base to peak amplitude? How much is the peak to peak amplitude? Everything is calculated by the software. Just you
স্যার
need
নেগেটিভ
to,
পিকটা কেন আসছে?
because it is compound,
Initial
na? It is not exactly an action potential. Okay.
Oh.
It is not exactly an action potential. You can't call it an action potential. It is a composite. Okay, so you are stimulating the median nerve and you are recording at the top of the belly. Okay, so there are lots of action potential that is summing over here and giving you this result. Correct?
Okay, sir.
It is not a single fiber action potential. Had it been a single fiber action potential, তাহলে just muscle এর যেরকম action potential হয় সেরকম দেখতে হতো, right? But it is not a single nerve fiber action potential. All the muscle fibers and all the nerve fibers, even median nerve is a thick nerve. If you dissect, you will be dissecting in your anatomy class, you will be dissecting median nerve. आप जब median nerve dissect करोगे तब आप देखोगे कि median nerve बहुत thick nerve fiber है, इसके अंदर बहुत सारे axons है, right? तो सारे nerve fibers and all the muscle fibers, they are generating this electrical response. So that is why it is called compound muscle action potential. Correct?
Okay, sir.
Okay. Now these are the parameters: the proximal latency, the distal latency, base to peak amplitude, and peak to peak amplitude. All these are given by this machine. Okay. So this is the machine. The machine gives you all the results, all the parameters. So this is, we have discussed median motor nerve conduction study, right? Median motor nerve conduction study. Now the sensory nerve conduction study as well. So in case of sensory nerve conduction study, we put the ring electrode over here. Ring electrode I have shown you already. This is the ring electrode. This ring this ring, you can put your finger into this ring, right? So this is called ring electrode. So in case of sensory measurement, sensory nerve velocity or sensory nerve conduction, so you will put the ring electrode over here. You will put the ring electrode over here. This is the stimulating electrode, and this one will be your recording electrode R. And ground electrode you can place anywhere, right? So this is again a sensory. So it is called sensory nerve action potential. Okay. So we are stimulating median nerve, right? We are stimulating median nerve uh, at the index finger, right? At the index finger, we are stimulating the nerve, and we are recording at the wrist, right? We are recording at the wrist. So again, we are getting the latency, and we will be measuring the base to peak and peak to peak, right? Okay. So this is the normative data. Again, you don't need to remember the normative data for the median nerve, median motor nerve, compound action potential. This is the range of normal latency. This is the range of amplitude, and this is the range of velocity. Okay,
Sure.
nerve conduction velocity. And in case of sensory nerve, yes.
স্যার আপনি বললেন ইন্ডেক্স ফিঙ্গারে আমি মিডিয়ান নার্ভটাকে স্টিমুলেট করবো না রিস্টের মিডিয়ান নার্ভটাকে স্টিমুলেট করবো?
Sensory nerve action potential we can measure both ways. Okay, so this is called orthodromic, and this is called antidromic. Your sensation goes from distal to proximal, right? A sensory nerve moves from distal to proximal.
Yeah.
Distal to proximal. So sensory nerve measurement, sensory nerve action potential, or SNAP measurement can be of two ways. I am not telling all these things because it is not required for you. So sensory nerve action potential, because you are asking, I am telling sensory nerve action potential we can measure orthodromic and antidromic, right? So in this example, we are stimulating at the finger and recording at wrist. That means it is orthodromic, correct? You can reverse this as well. You can stimulate at the level of wrist, and you can measure at the level of fingers, correct?
Sure.
But the common measurement, we put the ring electrode as a stimulating electrode on the finger, and we record at the wrist. So it is orthodromic measurement. And these are all the normal values of latency, amplitude, and velocity for median nerve only, because we are discussing only median nerve. In these ways, all the normal values are there for median nerve, for radial nerve, for ulnar nerve, for common peroneal nerve, for sural nerve, for tibial nerve, right? So for every nerve, we have the normal values, and these values also, this is adult values. This value also changes with age, right? So you see everywhere there is a range, and nerve conduction velocity, it is around 50 meter per second. Everywhere around it is 50 meter per second. So median motor compound motor action potential, compound muscle action potential, and median sensory, that is sensory nerve action potential, all the normal values are given here. You don't need to remember, okay? Because while reporting whether the nerve conduction velocity is normal or not, amplitude is normal or not, we always check with the normal, right? And even it is given in the machine, the normative data is already fed into the machine, and any kind of abnormal values, say for example amplitude is decreased or velocity is decreased, so it comes in bold letter, right? So that it is understandable that it is abnormal. Clear? Okay. Okay, now one thing. Now, how to diagnose whether the patient is having axonal neuropathy or demyelinating neuropathy? Simply, what for your level you need to remember is this. Okay, so compound muscle action potential amplitude. Compound muscle action potential amplitude. Remember this. Compound muscle action potential amplitude. It is decreased in axonal degeneration, and it is normal in demyelination. So this is axonal, and this is demyelination. Correct. So compound, when we are testing motor nerve, that means compound muscle action potential. So in case of axonal degeneration, compound muscle action potential amplitude is decreased, and it is normal in case of demyelination, right? But the conduction velocity is reversed. When there will be demyelination, you know, myelination is responsible for velocity. So when myelination is less, velocity is less, right? So definitely a case of demyelination, that means large fiber neuropathy, you know, for example, A alpha, A beta damage, what will happen? The myelination is gone, that means speed is gone. Myelination is equivalent to speed. Remember, myelination is speed, right? So when myelination is gone, speed is less, right? So conduction velocity, it is slow in case of demyelination and it is normal in case of axonal degeneration, correct? And in case of sensory nerve amplitude, again in case of similar thing is applicable over here, that nerve amplitude, action potential amplitude will be decreased in case of axonal degeneration. It will be normal in case of demyelination. See, and the conduction velocity, it is always less during demyelination. Okay, so these 4 points you remember, other points is not required for you. So amplitude and velocity, you just remember amplitude and velocity. So CMAP amplitude and velocity, CMAP amplitude and velocity, you remember, and SNAP amplitude and velocity, you remember. Just with these 4 points, you can differentiate between axonal neuropathy or demyelinating neuropathy. And I told you that demyelination neuropathy is usually due to demyelination neuropathy is due to large fiber damage, and axonal neuropathy is due to small fiber damage. And you know the examples of axonal, examples of small fiber neuropathy and large fiber neuropathy, correct? Any question?
Sir, এই সেন্সরি নার্ভ কন্ডাকশনটা মেইনলি তো স্মল ফাইবারে হয়তো
Sensory is the sensory may be small fiber, may be large fiber, because A delta and C, they are pain sensation, small
Yes,
fiber,
sir.
and
Okay.
A alpha is proprioception, again sensory.
তাহলে ডিমাইলিনেশন কি করে হবে? ওগুলো তো মাইলিন শীট নেই স্মল ফাইবারে।
Yes.
স্যার, এটা যদি মেইনলি স্মল ফাইবারের হয় তাহলে এখানে সেগমেন্টাল ডিমাইলিনেশন কি করে হবে? মাইলিন শীট তো নেই ওখানে।
मिनिमम माइलिनेशन है, लेकिन मिनिमम है. C is completely demyelinated, right? A delta is slightly myelinated and C is completely demyelinated. Clear?
ओके सर।
अरे भाई, A डेल्टा में माइलिनेशन है, कम है,
আচ্ছা
ठीक है, C में बिल्कुल नहीं है.
স্যার, তাহলে এটাকে ডিমাইলিনেশনের মধ্যে ধরবো কেন আমরা? নেই তো তাহলে।
A delta
A delta আছে তো।
আরে এই ডেল্টা তো আছে।
A delta is having myelination, but कम है, ठीक है?
ওকে 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 স্যার।
তাহলে আমরা যখন নার্ভ কন্ডাকশন স্টাডি করব, when we will be performing nerve conduction study, we will test the motor nerves as well as sensory nerves, right? So motor nerve, we choose very commonly motor nerve as median nerve, and sensory nerve is also median nerve in upper limb, because motor nerve, it is both sensory and motor, and also radial nerve is also has got sensory and motor component. Ulnar nerve has also got sensory and motor components. Okay, so for upper limb we will be testing all 3 nerves: median nerve, ulnar nerve, and radial nerve, and 2 components. You know, one nerve conduction study, it requires at least 2 hours to perform for a single patient, because upper limb you will be testing motor, median nerve, radial nerve, ulnar nerve on left hand side, then right hand side. Okay, then in case of lower limb, if you completely perform nerve conduction study for a patient, it will require minimum 2 to 3 hours minimum. It may require more, right?
Yes, sir.
Okay, any more question? Just there are lots of things like conduction block, temporal dispersion, F wave, H reflex, but this is never asked in undergraduate, never asked to MBBS students. So just remember the action potential amplitude and velocity. Velocity is equivalent to myelination. Whenever there will be myelination, demyelination, myelin sheath damage, velocity will be decreased. right? And whenever there will be axonal damaged, the action potential amplitude will be decreased, both peak to peak amplitude and base to peak amplitude, right? And your machine tells you how much is the value, and your machine compares with the normal value and tells you whether amplitude is high or low, whether velocity is high or low. Clear?
Yes, sir.
So
Yes, sir.
with nerve conduction study, you can just differentiate between axonal neuropathy and demyelination neuropathy. So you will be reporting that it is suggesting axonal neuropathy, or it is suggesting demyelination neuropathy, or it is suggesting mixed neuropathy. Clear? So if you see, for example, you have a clinic and you have got nerve conduction study equipment, and I am your patient. I am suffering from diabetes mellitus for a long time. So after 10 years, my doctor has prescribed me to perform nerve conduction study, and I am here at Ayush's clinic, and Ayush is performing my nerve conduction study. Okay. So my median nerve is chosen, and for example, my CMAP amplitude. Okay, in case of motor median nerve study, my CMAP amplitude is decreased. CMAP amplitude is decreased, and velocity is nerve conduction velocity is slow, right?
তো তাহলে তো লার্জ
Velocity.
ফাইবার হবে তো,
So it will be
লার্জ
both.
ফাইবার
My CMAP amplitude is decreased, CMAP amplitude is decreased, and conduction
Axonal
velocity is
demyelinating.
also decreased, right? Conduction velocity is also decreased. CMAP amplitude is decreased, conduction velocity is also decreased. So Ayush will be reporting that
Axonal
it is
and
a case of
myelinated both.
স্যার
it is a
দুটোই
case
হবে,
of
axonal
mixed
আর
neuropathy.
segmental।
Okay, my
দুটোই হবে স্যার।
CMAP amplitude decreased and conduction velocity is also slow. CMAP
So
amplitude
amplitude
decreased, conduction velocity is also decreased. So
দুটোই
Ayush will
হবে।
be reporting, yes, Ayush will be reporting that this patient, Ayan Goswami, has mixed kind of neuropathy, both axonal and demyelinating. Clear?
Yes, sir.
And if I am having, only decreased amplitude, but my
So
nerve
তাহলে
conduction velocity is within normal
তাহলে
limit,
axonal হবে স্যার।
স্যার শুধু
then axonal neuropathy.
হুম।
Clear?
Axonal.
Yes, sir.
Okay. So I won't repeat this class because this is only demonstration purpose, and you will face only few questions regarding axonal neuropathy and what is the difference between axonal neuropathy, demyelinating neuropathy. A very easy question from nerve conduction study, and no one will be asking you how nerve conduction study is performed, how the electrodes are placed. Okay. How to calculate nerve conduction velocity, it might be asked. Okay. But no one will be asking you the procedure, how to place the electrode, right? No one will be asking you. So it is just a demonstration topic, just like your pulmonary function test. I have discussed that it is a demonstration topic, no need to perform. Similarly, nerve conduction study is a demonstration topic, no need to perform. But actually what was required, if we had that machine, nerve conduction study machine, we could perform over here at the department, but as we are not having it right now, so we are unable to show you how to perform this. But I'll suggest you can see some YouTube videos for doing this test, nerve conduction study, so that your concept is 100% clear. Okay, so with this I'll be ending today's class.